I guess real quick, just intro on myself. I'm a physical therapist, as I talked about. Been practicing in the Chicago area for about 15 years. I'm the founder and owner of a practice called CustomFit Concierge. We provide concierge in-home physical therapy, kind of at the very similar business model to you guys, only with physical therapy instead of yoga. Is kind of the simple way to think about it. We currently have a team of about 12 therapists and one practice manager. And we service, I think, all the same areas that you guys do, so suburbs and city. As far as my background in education and whatnot, as discussed with Alex a second ago, kinesiology in undergrad, and then went to University of Iowa for physical therapy school immediately after that. Work background, I've kind of, I think, had a unique experience just kind of working for a lot of different types of companies, different sizes of companies prior to starting my practice, which was a really cool opportunity. So I worked for ATI Physical Therapy, went up into kind of managing clinics for them, got burnt out from that, wanted to get back into the nerdy side with Julie and get better at the skills and the clinical stuff. So I switched to a small private practice and kind of got more into continuing education and kind of crafting the skill set. In physical therapy, we call it manual therapy, which is kind of the hands-on technique work. So a lot of soft tissue mobilization, joint mobilization, hands-on stretching, stuff like that. So I dove into that for about 3 years and felt like I got better at my skills. And then I started getting sick of being in a clinic all day. And because in the PT world, we treat too many patients at once and get really burnt out of being inside all day. And I started to do some home visits on the side through an agency where I treated total knees, total hips, and a post-operative geriatric cases in the home. And I figured out that I really liked going to people's homes and being able to focus one-on-one and kind of having that space and time in between and not seeing as many people in a week. So I kind of fell in love with kind of the weekly routine of that. But then got sick of the insurance piece. So in PT, like dealing with Medicare and visit approvals and paperwork and kind of all that is another common complaint or frustration. So I learned of concierge where, that you take the insurance piece out and, fell in love with kind of that method of delivering care and started Custom Fit about 8 years ago. And then basically we take private clients just like you guys, give them really, really good care, treat less people, and, focus on the thing that we love to do is making people feel better. So that's the quick background on me. Today, I put together a little presentation here focusing on the shoulder joint, which I think is one of the more interesting anatomical pieces of our body. And crosses over quite a bit, into the yoga. I mean, everything crosses over into yoga, but the shoulder is, highly involved and challenging, I would say, when it comes to some of the yoga poses. And you tend to see a lot of pathology with shoulders in all different ages, a lot of injuries, a lot of surgeries. So there's kind of a lot of cool stuff to dive in when it comes to shoulder anatomy, shoulder function, and then kind of relating it to what we do each day with patients. So I try to kind of, I'm not someone who does a lot of these presentations, it's not something that I've done in quite some time. So bear with me a little bit on the organization of it and whatnot. And feel free to interrupt me at any time with any questions, or if you want to do shoot off conversations and stuff like that. If I'm getting too long-winded, too boring, tell me to move on. But I think we have about 10 slides here. We're going to start with a little bit of background and anatomy stuff. Julie's self-proclaimed an anatomy nerd, which I was very excited about. So she will be excited about this piece. So just the basics on the shoulder and kind of how it's put together. It's the articulation technically it's the articulation between the humerus bone or the upper bone in your arm and the glenoid fossa, which is kind of the socket part of the joint that is part of your scapula. The shoulder is unique in that it has kind of the most available range of motion out of almost any joint in your body, because the glenoid or the socket side of the joint is very shallow. So you always compare the hip and the shoulder. The hip has a much deeper socket, so it doesn't dislocate as much. It's inherently more stable. the shoulder is very shallow. So it's kind of like a marble sitting on top of a coaster, and there's a lot of movement that happens, and there's a lot of issues because of that, essentially. So it requires a lot of stability, stretching, mobility to be able to have a shoulder that functions really well and can do, all the crazy things you guys do in the yoga world. So most unstable joint in our body. So the most common joint to dislocate. Whoops. And then another terminology thing, the shoulder girdle is something we refer to a lot in physical therapy that kind of incorporates not just the shoulder, but kind of the surrounding joints and musculature. So it refers to 3 bones, the scapula, the clavicle, and the humerus, and then 4 joints. So you have the articulation between the clavicle and your sternum, which is the sternoclavicular joint. Then you have so that's medial. Out lateral, closer to the shoulder, you have the clavicle that articulates with the scapula at the AC joint on top of the shoulder. And then you have what we talked about before, the shoulder joint itself, or the I'm getting them all screwed up now. The glenohumeral joint. Thank you. There's technically 18 muscles that articulate with the shoulder girdle, which is pretty incredible. I remember that piece from school. So there's just a lot of muscles that connect to those 3 bones and have some play or piece of function when it comes to moving your shoulder girdle. So ligaments, just quick kind of background, like the difference between a ligament and a tendon. Sometimes people get confused on. Ligament connects bone to bone. So in the shoulder joint, the shoulder is surrounded by what's called a capsule, or the shoulder capsule. If you've heard of adhesive capsulitis or frozen shoulder, that's common pathology you guys have probably seen with clients. But the shoulder capsule is technically an enclosed unit of ligaments that helps to hold the humeral head on top of the glenoid fossa and provide some inherent stability to the shoulder joint. A tendon, so the difference, tendon connects bone to muscle. So those 18 muscles all have a tendon that connects to the bone, one of those 3 bones that we discussed before. So tendon difference, ligament difference. The most common tendon that we see issues with, everyone's heard of rotator cuff tears, probably had people with degenerative tears from falls post-operatively after rotator cuff surgeries. A lot of people call it the rotator cup or the rotator. You hear all these different slang terms that people think they're calling it the right thing. But technically, the rotator cuff is 4 small muscles that articulate from the scapula to the humerus. I would argue the most important kind of functional piece of the shoulder joint. And the way I think about it is we got the glenoid. We talked about that being really shallow. The humeral head sits on the glenoid. There's a lot of movement. The capsule holds it in place. And I think of the rotator cuff's job is keeping that ball centered on the glenoid. So with any position your shoulder's in, when you're lifting weights, when you're in down dog with your arms over your head, your rotator cuff is working really hard to try to keep the ball in the center of that plate, essentially. So it's very important. If it's not working properly, that ball is not in the right spot, and we tend to get pain, discomfort, or even in the extreme cases, dislocation, where it falls off the plate, essentially. All right, did that. Any questions about shoulder capsule, 18 muscles, kind of the background of the shoulder basics? Cool. Alex is going back to school today.
It's funny, I used to teach anatomy at the
Did you?
National Personal Training Institute years
Nice.
back. So it's
Nice. This is like kinesiology 101 here.
It is, but the shoulder, like you said, is so tricky. So it's almost 201 off the bat.
Yeah. So this slide outlines like kind of some of the major muscle groups we mentioned, there being 18 muscles that connect to the shoulder girdle. a little higher level than probably what we're doing today to know every single one of those muscles and their names and their functions. So we won't bore you with that side of it, but we just talked a little bit about the rotator cuff. I think that for me is the most important kind of functional group of muscles that, again, helps to stabilize the shoulder and is highly involved in everything that we do, and is highly involved with the problems that occur with people having pain, inflammation, discomfort, or tendon tears in the shoulder. If you remember one of the 4 rotator cuffs, I would say the most important one is the supraspinatus. So the supraspinatus originates superior to the spine of the scapula, kind of back by your shoulder blade or the top part of your shoulder blade. The tendon comes underneath the AC joint through something we'll talk about in a second, the subacromial space, and then connects to the front part of the humerus. 9 times out of 10, when you hear about a rotator cuff tear, it's the supraspinatus because of the anatomy, because of the position of where the tendon sits. The tendon is the most susceptible underneath the AC joint and tends to, I think a term we haven't used yet that we'll talk about in a second is called impingement. If you've heard of shoulder impingement, is essentially the kind of disease process that happens with a degenerative rotator cuff tear. It can also cause bursitis, if you've heard of an inflammation of the bursa in the shoulder. So underneath the AC joint, if I give you a visual here, you've got the humerus, you've got the glenoid, which is my palm, and then the acromion is basically the roof that sits over the top of the shoulder joint. In between this gap sits the supraspinatus tendon, the bursa, and the biceps tendon, kind of the 3 things that usually get injured or have inflammation or cause pain. So very common to see what's called shoulder impingement. Very common to see problems with the bursa, the proximal biceps tendon, or the supraspinatus tendon. So a lot of people think that when you tear your rotator cuff, it's often an injury or an accident or some form of trauma. I don't know the percentage off the top of my head, but I want to say somewhere around 90% of rotator cuff tears are actually just wear and tear over time, and they come on insidiously because of poor positioning, poor posture, a myriad of things, lifting too heavy weights, doing things over the span of your life that causes this diagnosis called shoulder impingement, that over time slowly tears the rotator cuff, and they call it more of a degenerative tear versus a traumatic tear. So probably the most common thing we see with the shoulder, males in their 50s and 60s tend to start to have, this problem pretty commonly. If it's not addressed, if it's not treated, if something's not changed, oftentimes they're the ones in surgery in their 60s-ish, getting the rotator cuff or the supraspinatus tendon repaired. I would argue, obviously, as the physical therapist that doesn't like to see people go to surgery too often, if we kind of catch this diagnosis early on and start to treat it, in their 30s, 40s, 50s, when they start to have some minor discomfort, oftentimes, if done well, you can prevent the rotator cuff from tearing later in life and ending up in surgery at some point. I hope you've had one, Julie.
I actually had a question on that because I remember in a lot of my training, it talked about when you bring your arm right above the shoulder, you always want to externally rotate it. So that way there's not impingement of the acromion. And I never realized, like you mentioned that like the rotator was with some of those, what people think of as like a rotator cuff injury, that it's like you said, maybe 90% or a certain percentage is impingement of that supraspinatus at the acromion process. And so I think about, and correct me if I'm not relaying back what you were saying, but, I talk about in my classes, the need to palms face upwards, that external rotation. But then I think about in down dog, if I see somebody who is internally rotating their shoulders, right, instead of externally, that could be like the danger, right? It's not just, they have discomfort, but that can literally cause that rotator cuff degradation. Am I thinking through that correctly?
Yeah. I wouldn't correct anything you said there. I think that's really accurate.
That was super helpful. I guess I never realized the impingement was what people typically call a rotator cuff issue. So that's fascinating. Yeah.
And I guess to piggyback off that kind of discussion, this might be getting a little technical, but going back to the analogy, like my fist is the ball, my palm's the glenoid, the roof over the top, the space in between is where the tendon sits. So when you lift over your shoulder, there's a term that we use in PT called the scapulohumeral rhythm. So in order for me to flex my shoulder to 180 degrees over my head, basically two things to happen. Is the humerus elevates like this, but the second thing is the scapula opens like this. So both things need to occur like this in order for my arm to get over my head without impinging, right? The humerus movement, the other third comes arguably through the mobility.
I think we're losing you, Jeff, for a bit.
I know, yeah, Jeff, your video is getting a little choppy. I didn't know if it was just me.
No, I think you guys froze for me as well. Am I back?
You are. But I missed when you were talking about like the glenohumeral rhythm, if I'm saying that correctly. That was where we started to get delusion.
Yeah. So in order to lift your arm over your head, you need to use both the scapular, what we call scapular abduction, which is the winging of the shoulder blade on your back, which basically opens the joint and allows the humerus to raise up over your head. So 2/3 of the motion comes from the humerus, 1/3 of the motion comes from the scapular abduction, opening the joint essentially. And what I find a lot is people have the humerus motion, they don't have the scapular motion. And a lot of people lack the ability of the scapula to abduct or to open up, for a myriad of different reasons. I guess getting, again, technical, but the serratus anterior is a muscle that articulates with the lateral border of the scapula and then comes underneath the scapula and basically functions to do what we call like a punching motion or sliding your shoulder outwards. But training that muscle to do that motion actually helps with that opening part of the scapula when it comes to coming over your head. So, for example, as a therapist, you're trying to, my job's to kind of figure out these mechanical issues with people, give them the things that are going to help. What I see a lot is they raise their arm up, oh, ouch, it kind of pinches, or hinges, or inflames. And then we can do some techniques to help with the abduction of the scapula, train the serratus anterior, have them raise their arm over their head again, and almost immediately they'll see improved pain-free range of motion because of the improvement with that scapular opening.
Oh my, that's so fascinating because I've heard of two things to help with that, and I'm obsessed with the serratus anterior. I know, I'm a total nerd. But just that idea I've heard called scaptia. It's like instead of bringing the arms out and up, you kind of bring them forwards and up. I've noticed when I have people, like if we work on strengthening the serratus, bringing arms forward and then up, there's less pinching. So that's so, and I again, so I'd never realized, I knew the serratus helped with the shoulder blades in place and stabilizing, but I never realized.
And so the other, if you're obsessed with the serratus, another little tidbit, like in yoga, you do a lot of weight bearing through your arms, right? Like high plank position, for example, or the down dog. But if you put someone in high plank and you see what we call scapular winging, so like you see that scapula just kind of pop off their back, they may or may not have shoulder symptoms, but that's a sign of weakness in the serratus anterior, essentially. So giving them lower level exercises and the one I usually go to is just called like a punch out. If they're laying on their back, they're working on protracting the shoulder blades, retracting. And you'd be surprised. A lot of people, even fit people, like they can't coordinate that motion, right? And then you can add weight to it, or you can do it in weight bearing positions, so clinical application there. You've got someone in high plank, ouch, their shoulder hurts, you see the scapular winging, just maybe dropping that term and saying, oh, that's a sign of weakness in your shoulder blade or your serratus. Drop them down to their knees in push-up position and have them do what's called a push-up plus, where they're in a weight-bearing position, pushing the floor away from them, separating shoulder blades and then retracting shoulder blades, and seeing if you can get them coordinating that motion a little better. And just as described before, you allow them to raise their knees up into high plank, and you turn that muscle on, and you see an immediate improvement in that.
Yeah. I love, and stop me, like, I don't want to derail, because you can tell, like,
No, this is good. This is good. And I think probably helpful for people that are listening, because you want things that you're going to see every day and actually use, And I talk about the rotator cuff anatomy, maybe not, but this is probably more important.
But this is so helpful to know, because the other question I had was with the serratus, does that, you mentioned, is there a way to help the scapula abduct, like abduction? So if there's tips that you have for that to help with that is one. And then two, I frequently will see people, do this, and I tell them, it's not lowering your shoulder blades, because those are meant to go up when your arms go up, but it's softening the upper trapezius. And I would love your thoughts, one, if that's accurate, and two, more tips. So I guess how to help people with that abduction of the scapula, and with how to soften.
No, one, I would say that's really accurate. The upper trap is the muscle that compensates the most, for a lack of something else with your shoulder, essentially. It's something that almost every person you talk to, complains of tightness, complains of pain, has kind of trigger points in the upper trap, right? And I think it's a very common misconception that we see over and over again is, okay, how do you fix that? The tightness in the upper trap. Do you stretch it? Do you get a massage? Right. And yes, you can do these things that will help it in the short term, right? Does it feel better after you stretch it? Yes. Does it feel better after you get a massage? Yes. You have those little hook things that people have that they push on their upper traps. I use those in the car quite often. Which is fine. Like it's good to have short-term relief, but really, if you want to fix it, if you want to see measurable progress on that improves over time, it's not the stretching, it's not the poking on it, it's strengthening the other muscles that it's compensating for, essentially, which usually is the rotator cuff, to the lower trap. So the lower trap functions to depress the shoulder girdle, or in those more extreme overhead positions, fully abduct the scapula, essentially. So I love doing exercises in prone that involve scap retraction. Like if you're familiar with kind of like I call them I's, T's, W's, Y's, like in a prone position. Those are really good, like middle and lower trap activation exercises. Probably the most common shoulder exercise that I give someone is simply laying on your stomach with your palms down. Like Julie mentioned, like externally rotating the shoulder puts that tendon in a little better position, makes it less likely to experience the impingement. So you're in prone on your stomach, palms down, head resting on the mat, and you're literally just trying to keep your palm on the mat and fully retract and depress the shoulder blades. It's a really nice position to train that motion. I think another common mistake people make is they give people too high of a level of exercise that they can't do yet, because they don't have the foundational part. So the foundational part is actually being able to retract and depress, which maybe for you guys that do yoga and are fit, is not difficult, but for most people, like, they've never used those muscles before. They don't know how to coordinate a proper scapular retraction. They don't know how to depress their shoulder girdle. So I like that exercise a lot for shoulders. If you give them one thing, it's like working that maybe into the yoga flow, just in prone, with a foundational scapular retraction.
I think that's kind of like, if you're familiar with locust pose, so it's a prone back strengthener, legs are straight. And so I usually counsel people to keep the palms facing the thighs just to help open. But to your point, palms are down.
You can go even further. Some people don't have the mobility to get there. But if they can get there, it puts the shoulder even more externally rotated.
Oh, got it. And then it would be like kind of drawing the shoulder blades back and down. Correct. Do they lift up at all, or is it more they're staying lower to the mat?
What's staying lower, the head or the
collarbone?
I like when people keep their head on the mat, because when people lift their head, they tend to then compensate through the upper traps, like you mentioned before. So being able to isolate just the scap retraction with their
Got it.
head resting on the mat, I like better. And then is we call it verbal cueing. Verbal cueing meaning what are you telling the person while they're trying to do it. Manual cueing, physically, where am I gonna touch? Where am I gonna poke? So verbal cueing, my cue is usually, I want you to take the front of your shoulder and move it away from the floor as far as you can. And that usually helps people kind of understand what you're trying to get them to do. Because you'll see people do a lot of funky stuff when you ask them to do a shoulder retraction, like they lift their head, they, lift their leg, I've seen it all. But if you say, oh, feel the front of the shoulder touching the mat, try to lift the front of the shoulder off the mat. Usually they can coordinate a little better. And then if you're, physically there with them, grabbing their shoulders, with your hands like this and having your thumbs kind of back by their shoulder blade and the front of your fingers in the front of the shoulder and literally just helping to pull the shoulder blades together. Tapping the middle trap and the lower trap with your fingers. I think this is later in the presentation, but manual cueing, they've done studies that actually show when you tap a muscle that the neural signal improves. So if they're having trouble activating their lower trap or middle trap, you can actually just physically tap the muscle kind of at a quick pace like this, and it can actually help the muscle contract better.
Fascinating. Yeah, this is wonderful.
Yeah, little things, but it's certainly things that as a yoga instructor, when you're physically with someone, like they're easy things to do, and apply for sure.
And you work with a lot of people who are probably not as comfortable going, right? And you likely know this, right? Not as comfortable going into a yoga studio. The majority of the people I work with are over 50, many are over 70, but they're super fit, right? But they're not familiar with, like you said, just those actions. And even with like the serratus, and I've been trying to help them find and strengthen, that was brand new for a lot of people. So it's not stuff that people are familiar with.
Exactly.
Yeah.
And people, the same people that are paying us, a lot of money for us to come see them are the ones that like to learn this stuff, and it provides a lot more value in the service that we're giving them, right?
Totally.
The big difference between, showing them the yoga pose, do this, than, being able to modify it and have a reason for it and do something that's going to make their body feel better, by changing your plan for the day. Like that's the value they're paying for.
Totally.
Right?
Totally. Yeah, no, spot on.
All right. So muscle groups, I kind of think of rotator cuff as one we talked about. And then the other muscles, I kind of divide into like muscles that help push, meaning like a bench press or a push up, versus muscles that pull. I would say in general, like big picture thing, middle-aged men are the most guilty with this, is doing way too much pushing exercises at the gym that tend to develop their chest or pecs, and then they have underdeveloped kind of retraction or pull muscles. So most of physical therapy and most of yoga, we want to focus more on the pull muscles in general. Or at least have a foundation with your pull muscles and your rotator cuff to then be able to do more push exercises safely and with less symptoms, essentially. This is a nerdy anatomy picture that Julie will probably look at later. But it's a anterior view and a posterior view, just kind of outlining like the actual visual of all those 18 muscles that, connect to the shoulder girdle in a way. I think we touched on, most of them. I think clinically for me, the most important ones are the rotator cuff, the 4 small muscles that help that humeral head sit in the glenoid properly and provide the proper stability for the shoulder. And then the middle trap and lower trap, I think, are the other two. And serratus, I'll throw that one in there because Julie loves it. But those 3, the middle trap, lower trap, serratus, are what help the scapula basically get, I call it seated or like retracted and depressed. And I guess back to your upper trap question, like the other thing that helps turn off the upper trap is depressing the shoulder girdle. And there's super nerdy, but there's a concept in physical therapy called, I'm going to forget it now. I just had it. Give me one second. Reciprocal inhibition. So going back to neurology, we talked about tapping the muscle improves the neural signal. if you want to turn the upper trap, the upper trap being tight theoretically is a neural issue, meaning the nerve signal is sending too much input to the upper trap to contract it too much, providing that tightness, right? So there's too much nerve activation. Reciprocal inhibition basically means you're facilitating the contraction of the muscle that does the opposite function. So this upper trap elevates the shoulder girdle, the lower trap depresses the shoulder girdle. So basically, by turning on the lower trap, it actually helps to block the signal to the upper trap, and that's the reciprocal inhibition. So when we're dealing with muscles that are too facilitated, which is the opposite of inhibition, in order to inhibit the neural signal to the upper trap, we want to do exercise to contract the lower trap or provide more activation of the lower trap, and that will inherently reduce the tension of the upper trap. So back to the people cramming, massage work and stretching on the upper trap, you might actually get more relief by skipping that and doing something that's going to activate the lower trap, because that's actually going to block the nerve signal and relax the muscle without having to massage it or stretch it. Doing all of them actually would probably be best, but if doing the one thing that's going to impact it more is going to be something to facilitate the lower trap.
Got it. Thank you.
I was going to say, are you telling me I can't just rip into my back with the...
No, I do that too. I do, because short-term relief is important, and it does help and it does reduce the symptom, but long-term fixing the problem, you're going to get more bang for your buck in the other category.
Which is super helpful to know. I've never heard of that actually, which is, I'm 100% going to shift to that now. I had one super quick anatomy question, if that's okay.
Go for it. Yeah.
The acromion process, are there different types / do you think about that and care about that?
Very good question. Yes, very good question. Yes. So when we were talking about that scapulohumeral rhythm and the impingement diagnosis, there is actually 3 types of an acromion process. You must have crossed paths with this at some point to know that question. But the bone of the acromion, if you're looking at my hand, don't quote me on this, but I believe type 1 basically means that it's pretty flat. That's the best one because it doesn't poke down into the important stuff. Type 1 is good. I think type 2 means that the angle of your acromion is angled down slightly, which makes you a little more susceptible to impinging when the shoulder moves, because you have bony anatomy that actually reduces the space for the tendon and the bursa and the biceps to sit. And then a type 3 acromion is the worst, where it's literally like poking down straight into kind of the rotator cuff. So there is, I think, a newer, everything's kind of trending more towards preventative, more towards early care, right? Yeah. There is a theory that says, hey, why not understand which type of acromion that you have? And if you have that type 3, when you're younger, go in and shave it off so that it doesn't tear your rotator cuff over the next 30 years. Because, a high percentage of the rotator cuff tear surgeries for people in their 50s and 60s have that type 3 acromion that sets them up to fail because of an anatomical abnormality, essentially.
Will you think about that if you're presented with a poor range of motion, high impingement, whatever it may be? Will that be a filter you add on to your sort of assessment to try to unroot what type they have? Or are you sort of like, well, we have to do the same things no matter what the type is?
Yeah. There's no way to 100% tell clinically without an X-ray. But if I'm someone, if I have a client and they've had X-rays or MRIs, like I always try to look at them or read the reports so that I know, because if I know the person has a type 3 acromion, that's part of the education that you're giving them. Hey, unfortunately, you have this issue that it's going to make it harder for us to achieve full range of motion, so it may affect, our essentially prognosis is worse when you have the prognosis basically means, how likely is it to improve? It's going to be worse if they have the type 3 acromion, because it's going to be harder to get full range of motion without pinching. The likelihood that the rotator cuff tear has progressed to something more severe is higher. So I think it's more of like a patient education thing, and it definitely impacts the prognosis for those people, or could impact what I suggest for them. For example, I'm trying to think of like an overhead athlete, right? Someone who does something, or an electrician or someone that has to do a lot of work over their head. If okay, they have a 50% supraspinatus tear and they have a type 3 acromion, and they're working for 8 hours a day, 40 hours a week above their head, that situation does not look good, right? So with that person, you're going to talk to them a little differently, educate them about why, they're getting this pain, why has it progressed to a 50% tear, because of that anatomical situation, right?
Makes sense. Thanks.
Really great, really good question. I think we hit on almost everything in the rest of my presentation with this discussion, which is great, but we've talked already about the subacromial space. Here's a visual of what the bursa kind of looks like. So a bursa is a fluid-filled sac that functions to pad tendons, pad anatomical tissue in our body. So there's a few common ones that we see that get inflamed a lot. Probably the most common one is in the hip, on the lateral side of the hip. The second most common one is the shoulder, the one in this picture. But we do have bursa, other bursa all over the body. Knee bursitis also is a common one that we see. But this gives you a visual of what the acromion looks like. This is that space. This tendon coming across here is the supraspinatus, which is the most common rotator cuff tear. And then this is the biceps, the proximal biceps tendon that also comes through that space. So it's kind of a visual of all the tissue that tends to get impinged with the most common shoulder diagnosis. We touched on all of that. Yep. This is low-level kine stuff that Alex could probably teach us here, but just these are we talked about the shoulder being the most mobile joint in your body, and these are just the terms that we use for the different movements of the shoulder. In yoga, you're using all of these movements essentially. So flexion and extension, flexions overhead, extensions back behind you, essentially. Abduction and adduction. So the way I remember this, or we were taught it in school, adduction is going towards the body. So you're adding towards the body. And abduction is going away from the body. You're going rotation. So external rotation is going to be like back in this field goal position, or with your elbow at your side away from your body is external rotation. Internal rotation is going to be the opposite direction, going towards your body or towards your belly button. And then horizontal abduction and adduction. So horizontal adduction, adduction towards is going to be reaching across your body. And then abduction or away is going to be out to the side, essentially, or that like a T position when you're in prone. So basically there's 3 planes there. So you have, oh man, if I'm going to remember this one, the sagittal plane, the transverse plane. So transverse plane is going to be the abduction or horizontal ab and adduction. The sagittal plane is going to be the flexion and extension. And then I think the frontal plane, yes, is going to be the abduction this way and then adduction down. 6 directions essentially. This is a list of, I guess, what I kind of put together of like, we've talked a lot about the most common one, which is what I wanted to focus on, being the shoulder impingement and kind of those 3 tissues in the subacromial space. But obviously there's some other issues with the shoulder that we can see. We mentioned adhesive capsulitis is one that's not on this list. But these are kind of, I guess, the categories of shoulder issues that we're going to see. So in older individuals, usually, we get a lot of arthritis of the shoulder, right? So arthritis, technically, you can think about it as the cartilage is wearing away. So you've got the head and the socket again. Cartilage is covering the socket side, covering the head side to basically have padding in the joint for when we weight bear through the joint. The literal diagnosis of arthritis is that cartilage is wearing away. So we have less padding in the joint, which tends to provide less joint space, which means less movement, essentially. There's also an inflammatory component to arthritis. So most of the time when you do have less padding, less cartilage, there's oftentimes a low level of inflammation because of the contact that's happening between the bones with less padding. The arthritis usually progresses in 3 phases. So if someone has range of motion up over their head, like you wouldn't see a decrease in range of motion, but they go on an x-ray and they have some mild cartilage, wearing away, that's usually the lower level or the least severe. The second level, usually you're able to notice the range of motion loss and they have some form of pain on an x-ray. There's even less cartilage. And then the end stage or stage 3 arthritis, like a lot of those people can't even lift their arm over shoulder height. They have a lot of clicking, popping, grinding in the joint, tend to have, chronic pain associated with it. And these are the people that generally go in for a shoulder replacement surgery. So unfortunately, arthritis is something that's an uncurable, progressive type thing. So there's not something they can do yet to basically solve the problem. But the gold standard treatment for arthritic joints now is joint replacement. So you see a lot of them in the knee, in the hip. They do some ankle, but not as much, and shoulder are the most common ones.
I have a question, Jeff, and I'd love your perspective. And I've heard kind of more with like ankles and knees where like joints will pop and crack, right? When you move, but there's not pain.
Yeah.
What is I've heard different things of that, the muscles kind of moving over the soft, the soft tissues moving, it's moving over the bone.
Yeah.
When is that an issue? And is that true? Like,
really good question.
Yeah.
Yeah, I'm glad you brought that up. So the medical term that we use for that is called crepitus, if you've heard that term. People tend to get pretty obsessed with their joints cracking and popping, right? Clinically, they complain about it a lot. I guess my perspective is it's very common that joints pop and crack. And then I divide it between non-painful crepitus and painful crepitus. Yeah. So non-painful crepitus is almost everyone. There's almost, and in any joint, obviously, that has some pathology or some issue, crepitus is typically present, right? Very common in the shoulder, very common in the ankle, very common in the knee, very common in the spine. So non-painful crepitus, I would say, is normal. Like that's not an abnormal thing per se.
Yeah, because I definitely have that. So I'm always like, okay, it's not hurting, but
yeah. I think maybe another concept we haven't touched on yet that's pertinent to this discussion is hypermobility versus hypomobility, just in general. So if you look at any individual, they're usually one of two things in general anatomically. They're either hypermobile, meaning their ligaments tend to be lax and they tend to have naturally really good flexibility. This is most people that are involved in yoga, to be honest with you, right? The other side of that is hypomobility. So hypo is low mobility, hyper is high mobility. So hyper, excessive range of motion, essentially inherently unstable joints, loose, lax ligaments. Hypo, tight ligaments, lacking range of motion, tend to have difficulty doing a lot of yoga poses. So this is my personal opinion, is in the fitness world, right? We tend to gravitate to things that we're better at, right? So we tend to see a lot of younger females who are hypermobile going to yoga, right? Yes. Because their body is set up to be more effective, to be more able to do, a higher level of yoga, right? I unfortunately am hypomobile, so I was built pretty tight. I'm the one that would benefit more from yoga, right?
Yeah.
So
that's what
but a lot of hypomobile people are generally scared of yoga because they are self-proclaimed not flexible. Oh, I'm not going to be able to do it. Oh, I'm not. And they don't like to do something that they're not good at.
Yeah.
Right?
They need the mobility. The hypermobile people need the stability, right?
Exactly. Yeah. And not to say yoga is not good for both, because it certainly is.
But it's how you teach it, though, exactly to your point, and making sure people aren't just resting in their joints, but actually, in a low lunge, firming the back of the thigh that you're stretching, firming that buttock, right? Like, don't just sink and like throw your, I'm very like anti-crazy yoga pose.
Yep. No, I'm glad you brought the question up. And I would say, I don't know if I fully answered it yet, but like non-painful crepitus, very common. What's cracking, you don't always know. I think it's accurate to say that sometimes it's tendon moving over bone. Sometimes I think it's ligament and bone on bone clicking, in the patella joint in the knee, for example. Like the patella sits in the front of the knee and it's a floating bone that clicks and pops a lot in the front part of the knee. So I would say it's tendons, also cartilage and bone, moving in a way that it's just rubbing or touching each other. Technically, when it becomes a problem is when it's painful, right? And I would say most often it's not, but there are cases with pathology or inflammation where, it cracks and it hurts. So in those cases, then it is abnormal, and you got to figure out, what is inflamed and why. But there's also sometimes techniques you can use as an instructor, as a PT, to reduce that non-painful crepitus. In the shoulder, it generally always goes back to the position of the shoulder blade. Getting someone more retracted and depressed is usually going to be something that reduces crepitus and reduces non-painful crepitus. Not always, but that's usually the case because of the scapulohumeral rhythm, because of, what we talked about before with reducing the likelihood of impingement. Did that
It
answer?
did. Yeah,
Yeah.
that was great. Thank you.
Okay. And then I guess back to hyper and hypomobility, like hypermobile people tend to crack a lot because their joints are moving too much and there's more of that contact between that anatomy. Although hypomo people always or often crack as well because their ligaments are too tight and there's not enough movement. So generally everyone cracks. It's a problem if it hurts, essentially. Okay, so we talked about arthritis, joint replacement. We talked a lot today about impingement and rotator cuff problems. Going back to the hypermobility, another category of shoulder problems is instability, with the most extreme case of people that have dislocated their shoulders. So you tend to see that injury in younger athletes. The most common mechanism is like if you watch baseball, like if a baseball player dives and their arm is up over their head and they're flying through there and they land and their shoulder gets jammed kind of up over their head forcefully, the humeral head can actually fall off of the glenoid rim. 99% of the time, the shoulder joint dislocates inferior and medial. So the shoulder, it comes off down and forward because of the force that's coming up extreme overhead. Difference between dislocation and subluxation, I guess another terminology. So dislocation means it comes out and stays out and has to be physically, usually by a doctor or the emergency medicine people, athletic trainers. They have to relocate the shoulder to get it back in place. Subluxation means basically it slid out and came back in, and oftentimes there's injury associated with that. So we commonly see one thing we haven't touched on anatomy wise is there's part of the cartilage in the joint is called the labrum. If we've heard of the hip labrum and the shoulder labrum. If you're looking at the glenoid is my hand, we talked about the cartilage covers the glenoid to provide padding. The labrum is a circular shaped piece of cartilage that lines the outer rim of the glenoid that functions to help the socket deepen and provide stability so that it doesn't dislocate or sublux. So you can think of it as kind of something that helps to hold the shoulder in place. And it's technically cartilage, so it doesn't connect to muscle. It doesn't connect bone to bone like a ligament, but the cartilage is sitting there effectively improving the inherent stability of the socket. When someone dislocates, they often tear the labrum. As you imagine, if the shoulder falls off the socket, it's going to contact the labrum and the bone kind of on the way out. So we see a lot of glenoid rim fractures and then labral tear post-dislocation. Sometimes that requires surgery, sometimes it doesn't, but that is the most extreme case of instability. I would also lump in like super hypermobile people. They may not have an injury or a problem, but they are very hypermobile, meaning they don't have a lot of inherent stability from their ligaments. They're also in that category of instability, or they're at risk to dislocate. And they, like Julie said, they need stuff that's going to help improve the stability of the shoulder because they don't have it anatomically. And then obviously there's a lot of trauma and fracture. Like I said, almost above 90% of shoulder problems are non-traumatic, but there certainly are traumatic shoulder problems. You see a lot of clavicular fractures, AC joint separations, proximal humerus fractures in older individuals with falls, dislocations in young athletes, Rotator cuff tears in the older population that falls are kind of the most common ones. We mentioned adhesive capsulitis, which is not on this list as well. It's kind of a very interesting diagnosis of the shoulder that comes on insidiously, but basically just the capsule of the joint becomes inflamed and it takes about a year to go away. It's something that's really frustrating and painful for people. The shoulder gets super tight. And no matter what you do, it takes a year to go away. With treatment, it improves the pain and the mobility as you're going through it, but kind of an interesting diagnosis for sure. And then obviously post-operative. So people probably have clients that have had shoulder surgery, for something along in their lifespan, and then they're, still recovering or, compensating because of probably not finishing their PT or working hard in their PT coming out of the shoulder surgery. So rotator cuff tears, labral repair surgeries. What are the other and then proximal humerus, what they call ORIF, open reduction internal fixations, where they have to go in and put plates and screws in the bone because of a severe fracture. And then the total shoulders, both the traditional total shoulder and then what they call a reverse total shoulder, which they actually reverse the anatomy of the joint in a reverse total shoulder, which is pretty fascinating. I would say those are probably the 5 most common surgeries that we'll see. But honestly, the rehab is very similar to all of them. You're getting range of motion back, you're getting strength back, you're trying to progress the activity in a way that gets them back to their desired, functional level. Questions on any of the pathology of the shoulder? Cool. Sorry, I'm long-winded. We're going to run out of time here, but that's okay. This is fun. One thing we haven't talked enough about probably that we can probably end with here, but the impact of the spine on the shoulder. So we talked about posture being really important. So the thoracic spine or your upper back, someone who's really rounded there, they're going to have a lot more difficult time getting their shoulder girdle and their, body in a position to retract and depress their shoulder blade. So the mobility of the spine being able to extend is something we work on a lot in shoulder rehab and shoulder treatment, because it sets up the shoulder girdle for being in a better position, essentially. And then the cervical spine or your neck, going back to the neurology piece. So every muscle has a nerve that has to work properly to activate the muscle to provide strength, right? All of the nerves that come out of your neck provides the power or the strength to the muscles in your shoulder. So the position of the neck can actually affect that neural signal to the muscles in the shoulder. So theoretically, you could have someone with really bad forward head posturing. You're doing yoga with them and their head's, forward, and they can't get back to that good position. But just functionally having that head forward can actually cut off some of the neural signal to their shoulder muscles. So if you can get the person in more of a chin tuck, more stacked, proper cervical position, it actually increases the neural signal to the shoulder muscles. So it's not just the posture, it actually can help strengthen the shoulder muscles just by the position of the neck, if that makes sense. I'm going to move on just because we're running out of time. A term that I go back to a lot in shoulder and upper body stuff with PT almost describes every problem we see in the upper quarter of the body is called upper crossed posture. So it's basically just a pattern of tightness and weakness that we see with poor posture in almost every individual. So the red part of this icon is the weak parts. So people tend to be weak in their neck flexion, which is what we call chin tuck, where you're trying to get your spine in a better position by tucking your chin. There's muscles in the front of the neck that provide stability to your neck to keep your head in a good position. And then in the back, we talk about the middle and lower trap being really important for retracting and depressing the shoulder girdle. So doing exercise to strengthen or facilitate these 2 muscle groups is involved in almost every shoulder problem. And then the other side of it, where we're tight in the upper trap, and we're tight in the levator scapula, which we mentioned, and then we're tight in the pecs in the front, which pulls your shoulders forward and up in a bad position. So almost every shoulder situation that you could think of, like the rehab or the getting better at it, involves basically this little simple equation. We want to strengthen the front of the neck, strengthen the back lower part of the shoulder blade. And then we want to stretch and inhibit these tight areas. And if you can do that, most shoulder problems get better. Most neck problems get better. So kind of a really important, simple way of kind of thinking of it. Are we good on time, or you guys need to run? Noon right now. We're good. Why is it important for yoga? I mean, I think the discussion we had today highlighted pretty easily why it's important. We're working with people one-on-one. Doesn't matter if it's PT, yoga, personal training, whatever it is. Having a more in-depth understanding of the body and the anatomy and the underlying problems with it is going to help you deliver whatever care you're delivering in a better, more valuable way for the client. Shoulder or yoga specifically obviously can be great for improving shoulder mobility, adding shoulder stability, which is kind of the two main things that people need to help improve their shoulder function. I just said mid to high level yoga requires a high level of stability to bear weight through the upper body. So it can be something that's really challenging for people that don't have the mobility or stability. And if used, too aggressively, can be, a way that people injure themselves, right? I said almost everyone has some, problem with their shoulder at some point in their life, I would say. So it's, something that is very common, right? With almost every client, I would say that we see, has some shoulder problem at some point in their life. So I would assume it's similar for you all in the yoga world. And then, you guys are going to field complaints about shoulder issues, pretty commonly, right? So hopefully the talk today, gave you at least a few pieces of insight or things that you can talk about with clients or things that you can do with clients that might help you field these complaints, with your clients in a more effective way. Important takeaways. I think this is the last one. Yeah. I think we touched on most of this stuff, but I'll run through it and then we'll wrap up. We touched on being like encouraging clients to seek treatment early, I think is huge. Most people inherently, I mean, we're all probably guilty of it. Like we don't go seek help for our injuries until they're bad enough to where they're impacting what we can do, right? We all have these little nagging things that bother us that we think might take care of themselves. Usually they don't. So as PTs, we like to see those people that it's not bad yet. And they're at kind of the part, take shoulder impingement, for example, they're still doing yoga and they're still able to do everything, but they feel discomfort, right? And they just work through it. And they, if they don't do anything, theoretically 10 years down the road, it's going to be worse. And then they won't be able to do the yoga and then they're going to seek help. But if you start the treatment now, we can have an impact on the tissue in a way that may prevent the rotator cuff tear from happening. So seeking early guidance and treatment, it's hard to get people to do it, but it's something that you guys for sure can have an impact on if you can be that person that brings it up and says, hey, this is beginning to be a problem. Like, let's get ahead of it and try to get this figured out and, work with orthopedic or PT or whoever to kind of help address this and do it together in a way that, makes the health of their shoulder over their lifespan, a lot better. We talked about the spine positioning piece of why the shoulder can hurt with the thoracic spine and the neck. We talked about scapular depression, retraction, and depression being the most important kind of positioning thing to provide for patients that are having shoulder complaints. This number 4 is kind of a list of just like the main focus areas that we would typically be focusing on in physical therapy that you all can focus on as well with people with shoulder issues. But stabilizing the scapula, strengthening the rotator cuff, stretching the pec and posterior capsule. We didn't talk about the posterior capsule, but the posterior capsule is ligaments in the backside of the shoulder. Most people that have a shoulder issue have the way to test for it is being able to reach behind your back up between your shoulder blades. In general, that's usually a sign of whether your posterior capsule is tight or not. A high percentage of the time when people have shoulder problems, if you ask them to reach and then compare it to the other side, they most often cannot do it. And that's a sign that the capsule in the back is tight. In order to stretch the capsule, it's kind of the crossbody positions or yoga poses, like, I don't know the terminology, but like in a child's pose where you reach the arm through and rotate through across the body. It's going to stretch the ligaments in the backside of the shoulder. Or doing a stretch where you actually put your arm with your hand out between your shoulder blade and stand up against a wall, and it kind of hurts and stretches. But that's the way to stretch the posterior capsule. The pec, doing a doorway stretch, or, there's plenty of yoga poses that open up the shoulder into horizontal abduction or external rotation for stretching the pecs. Chin tucks we talked about is strengthening the deep neck flexors, providing a better position for the neck, and then thoracic extension. So a lot of that in yoga, trying to get your head up and your chest tall and extending through the upper back. I just put do not ignore and push through pain. A lot of clients think that, harder is better, push, ignore it, it'll get better. Usually that way of doing it doesn't work, and just, arguably is worse for their health long term. So trying to be sensitive to what people are telling you and actually trying to modify or adjust or, recommend seeing someone for it or earlier than later. It's hard to do that, and sometimes it's easy to ignore, and, sometimes they can get away with it and it gets better, but try not to make that error. And then we talked about a little bit about manual cueing and verbal cueing. So those things can be really powerful ways to improve your client's ability to do what you're trying to get them to do with less pain, and can provide a lot more value, from a client and business perspective. The more manual and verbal cueing that you're doing, the more valuable your session is, arguably, I think, for your client. The more you're going to have a likelihood of retaining that client, long term, giving them, more value in their session. Random thing, I'm a big proponent of icing. So with anyone having pain, the root cause of it most likely is something to do with inflammation. Inflammation is cells and blood flow going to the area that is basically the physiological cause of pain, essentially. Ice helps to reduce inflammation. So I'll leave you with this example. I have, she's in her 80s, probably. She has 2 rotator cuff tears. She's not going to have surgery. Both shoulders hurt, very low functioning, and we started treating, kind of hard to treat, getting a little better. And then one day I was like, hey, for the next week, I want you to ice every night for 20 minutes, 6-7 days in a row. And then I'll see you in a week and tell me how that goes. And I come back the next week, she's like, I iced every day and my shoulders feel great. And then all she really needed was something that was going to impact her inflammation on a more regular basis. So with almost any injury or complaint, if there is some form of inflammation, if you can get someone putting ice on it on a daily basis, it usually helps the inflammation. It's not rocket science, but it's something that people don't do. And it takes a little bit of discipline, takes a little bit of that extra step. But I thought I'd mention that as something that you can tell your people to do if they're having something that's irritating them. And that's it. Sorry for taking up